Hi everyone. Until yesterday, we have discussed about the introduction to the autonomous nervous system. So, what we covered in that, we have discussed about introduction to ANS and the divisions of the ANS and the organization of the autonomous nervous system, both the sympathetic and parasympathetic nervous system. And we have discussed about the basic points like origin, and we have discussed about the basic functions and neurotransmitters in the preganglionic nerve endings and postganglionic nerve endings, and we have discussed about the receptors as well. Okay, basic intro to the neurotransmitters and receptors. Okay, so then in this class we'll continue with the parasympathetic drugs. Okay, so parasympathetic nervous system. Before we enter into the parasympathetic drugs, we should know some concept regarding the cholinergic transmission. Like we should know about what is the neurotransmitter here, how it is synthesized, and how it is stored, and how it is released, and what are the triggers for release, and where it acts, and how it is degraded, how it is broken down. Okay, everything we'll discuss in this topic. Along with that, so this acetylcholine itself does not produce the effect, right? So that's why it must be act on the receptors to produce the effect. Okay, so this acetylcholine will act on which type of receptors, and these receptors present on where, and which category of receptors these are. Okay, and what are the transcellular signaling mechanism, and everything we'll discuss in this class. Okay, so then first we'll start with the synthesis of acetylcholine: synthesis, storage, degradation, and action and release of the acetylcholine. Okay, so in that, first, how the acetylcholine, where the acetylcholine is synthesized. So acetylcholine is synthesized within this cholinergic nerve endings, locally within this cholinergic nerve endings. By what? So first the acetyl-CoA is formed through what? So here acetate, coenzyme A, and ATP. So they all combine to form the acetyl-CoA first. So the formed acetyl-CoA will combines with the choline. Okay, so and in the presence of choline acetyl transferase, so these two combine to form the acetylcholine. But here the rate limiting step in the synthesis of acetylcholine is this choline is not readily available within these nerve endings. Okay, it must be taken from outside. Okay, so and the transport of this choline, uptake of this choline into these nerve endings is not a simple process. It's not a passive process. It's an active process. With the help of transporters, it will be taken up into the nerve endings. So how? With the help of this sodium and choline co-transporters. With the help of these transporters, this choline will be taken up into the cell. Okay, so then it will continue with the, it will combines with the acetyl-CoA. Then in the presence of choline acetyl transferase, it will combine to form acetylcholine. Okay, so here taken up of choline into the nerve endings is a rate limiting step. Okay, so then after the synthesis, it won't be present as it is within these nerve endings. Okay, so it will be stored. If it is present as it is, it will be degraded rapidly. Okay, so for that it will be taken up into these vesicles for the storage. Okay, into storage vesicles. So here the transport of acetylcholine for the storage into the storage vesicles is also not a simple process. It is also the active transport process. Okay, so this acetylcholine is transported into the storage vesicles with the help of vesicular acetylcholine transporters. With the help of vesicular acetylcholine transporter, so this acetylcholine will be transported into the storage vesicles. Okay, until now we have discussed the synthesis and the rate limiting step in the synthesis, and storage, how the storage will done, will discussed. Okay, and then here whenever any stimulus comes, so this vesicular membrane can fuses with the neuronal membrane and causes the release of acetylcholine. Okay, so where, how, what causes this? So when it receive any stimulus from outside in the form of action potential, so which causes the influx of the calcium into the cell. Okay, so this calcium causes the fusion of this vesicular membrane with the neuronal membrane, and then by the process of exocytosis, the acetylcholine will be released into this synaptic cleft. Okay, so here after the release, so this acetylcholine, some of the acetylcholine, among the released acetylcholine, some of the acetylcholine will act on the corresponding receptors. So what are the receptors for acetylcholine in case of parasympathetic nervous system? So receptors for acetylcholine are both muscarinic receptors and nicotinic receptors in case of parasympathetic nervous system. Okay, so it may act on either postganglionic nerve endings. Okay, either here it will act either from the postganglionic nerve endings, either it will act on the effector organ, on blood vessels, on heart, etc. Okay, so like that, some extent will act on the receptors to show effect. Okay, and some acetylcholine will acts on the some acetylcholine is rapidly degraded by the enzyme present here. Okay, so here what is that enzyme? Acetylcholinesterase or butyrylcholinesterase. Here acetylcholinesterase we considered as the true cholinesterase. Okay, so butyrylcholinesterase, which is apart from here, it is also present in plasma, so which is considered as pseudocholinesterase. Okay, so in the presence of this acetylcholinesterase, so in this synaptic cleft, acetylcholine is broken down into choline and acetate. Okay, so acetylcholine will be degraded by this process. Okay, and this choline again is taken back into the. So here among this, some will act on the receptors and some is degraded by the cholinesterase, and some this choline is again taken back for the synthesis. Okay, so among all these steps. Okay, so here synthesis, storage, release and degradation. Okay, so all these steps we can block with the help of drugs. Okay, so some here, so when we block all these steps, here when we block synthesis, acetylcholine synthesis will be inhibited, and when we block the storage of acetylcholine, availability of acetylcholine within the synaptic vesicle is decreased. Okay, and then when we block the release, availability of acetylcholine here we decreased. Okay, but when we inhibit the acetylcholinesterase, here acetylcholine levels are increased here. Okay, we are inhibiting the degradation. Okay, so then we'll discuss these drugs. Here coming to here, so here how the synthesis is done with the uptake of choline into this nerve endings, right? So with the help of this choline and sodium co-transporters. Okay, so this transport process is blocked by this drug, that is hemicolinium. Okay, so after that in this way the synthesis of acetylcholine is inhibited. So then upon this acetylcholine must be stored within the storage vesicles. Okay, so this is with the help of vesicular acetylcholine transporters. Okay, so these transporters are blocked by the vesamicol. Here hemicolinium blocks the synthesis, vesamicol blocks the and vesicular. Okay, so vesamicol blocks the vesicular transport of the acetylcholine. Okay, and this release is blocked by the botulinum toxin. Okay, so these are some of the drugs that will affect the synthesis, storage and release of the drugs. Okay, so then here another category of drugs also there, right? So here the released acetylcholine, in order to show the effect, in order to show parasympathetic nervous system effect, it must act on the corresponding receptors. Which receptors? Muscarinic and nicotinic receptors. Okay, so here whatever the drugs that acts by stimulating these receptors are considered as the parasympathomimetics. Okay, so whatever the drugs acts by blocking these receptors are considered as the parasympatholytics. Okay, so some here among the parasympathomimetics, some may directly acts on these receptors. They have structural similarity with acetylcholine and directly acts on these receptors and stimulate these receptors. And some other drugs, so that increases they do not directly bind to this receptor, but they are acts by increasing the availability of acetylcholine. If acetylcholine is more available, more will be the stimulation of these receptors, right? So how this happen? By preventing the degradation of acetylcholine. How? By inhibiting this acetylcholinesterase. Okay, some other drugs are considered as the anticholinesterases. Okay, so here synthesis inhibitors, storage inhibitors, release inhibitors, and then anticholinesterases, direct acting parasympathomimetics and parasympatholytics. enzyme, and ganglionic stimulants and ganglionic blockers. All these are the drugs comes under the parasympathetic nervous system. Okay. So here until now we have discussed about acetylcholine. Okay. And then we'll continue with the receptors. Okay. Here here coming to the receptors, what are the receptors for this acetylcholine? So there are two kind of receptors. What are those? Muscarinic receptors and nicotinic receptors, right? So here this muscarinic receptors are present on the effector organs and also on the CNS majorly. Okay. So this nicotinic receptors are present on the neuromuscular junction and autonomic ganglia. Again these muscarinic receptors have various types, and again these nicotinic receptors have different types. So we'll discuss the basic points about these receptors, and so then we'll discuss the various types of these receptors and their location and their transducer mechanisms and the selective agonist and antagonist and everything we'll discuss. Okay. Then here, so coming to here, first muscarinic receptors and nicotinic receptors. So here, so muscarinic receptors are comes under G protein coupled receptors in the body for every ligand, for the hormones, for the neurotransmitters, from the local mediators. Okay, for everything the receptors are present. Okay, all those receptors are broadly classified into four types. What are those? So nuclear receptors, G protein receptors, inotropic receptors, and enzyme linked receptors. Among these four types, here muscarinic receptors are comes under the G protein coupled receptors, and nicotinic receptors are comes under the inotropic receptors. Okay. Among that, here always the G protein receptors they associated with the release of second messengers. They act by releasing the second messenger. Okay, either in the form of cyclic AMP or IP3 or DAG. Okay, so these inotropic receptors, nothing but when acetylcholine binds here to the nicotinic receptor, and which causes the opening of this ion channel and causes the influx of ions. Okay, so here when the muscarinic receptors are stimulated, so this G protein is getting activated and causes the release of second messenger. Okay, so in this way these muscarinic receptors and nicotinic receptors will act. Okay, and then here through the release of the second messengers, either they cause the opening of various ion channels. Here in case of muscarinic receptors, they are associated with the opening of calcium and potassium channels, and here they are associated with the opening of directly they open the various cationic channels, especially the sodium and calcium. Here, so coming to the effects, here muscarinic effects, some of the muscarinic effects are inhibitory. For example, on heart, which decreases the force of contraction, which decreases the heart rate, which decreases the AV conduction. And in case of smooth muscles, they increases the contraction. Okay, some are inhibitory effects and some are excitatory effects. So but here in the nicotinic, all are excitatory effects. For example, here which increases the skeletal muscle contraction and which causes the stimulation of ganglia and all this. Okay, and then coming to the location, so these muscarinic receptors either present on the effector organ. What are the effector organs here? Whatever the parasympathetic nervous system is distributed to. Okay, so here on heart, on smooth muscles, on glands. Okay, so on eye, etc. Okay, in all these organs, these muscarinic receptors are present. Along that, some extent in CNS also these muscarinic receptors are present. Okay, but less commonly they are present on the autonomic ganglia. But here these nicotinic receptors, so they are present on these autonomic ganglia. Okay, so here this is the ganglia connection of two neurons, right? So here it is present on the autonomic ganglia, or else it is present on the junction of neuron and muscle, skeletal muscle. Okay, neuromuscular junction, and also which is present on the adrenal medulla. Okay, so on kidney we have adrenal gland, right? So on adrenal medulla it is present. Okay, and then so which is basic info, and then there are agonist, selective agonist. They only stimulates the muscarinic receptors, and some drugs only stimulates the nicotinic receptors. So here a selective agonist for the muscarinic receptor is muscarine. Here selective agonist for nicotinic receptor is nicotine. Okay, so nicotine won't stimulate muscarinic receptor, whereas muscarine won't stimulate the nicotinic receptor. It only stimulates muscarinic receptors. Okay, and then again in the muscarinic receptors are of various types. Again the nicotinic receptors are of various types. Again the among the muscarinic receptors, so these G protein coupled receptors broadly we classified into GQ, GS, GI. Okay, so among that some of the muscarinic receptors are comes under GQ subtype and some are comes under the GI type. Okay, and then everything we'll discuss in the next class. Okay, so here there are again the muscarinic receptors are classified into 5 types, but here we discussed about only 3, so remaining 2 are having less important. Here M1, M2, M3, M4 and M5. Okay, so among all these, all the odd one, M1, M3, M5, so these are GQ subtype. Okay, always the GQ subtypes, in the GQ subtype second messenger is IP3 or DAG. Okay, so they activates the IP3 and DAG, whatever, either it is muscarinic or either it is histamine receptors, either it is whatever the receptor type it is. If it is GQ, so intracellular signaling pathways IP3 or DAG. Here IP3 and DAG in case of M1, M3 and M5. Okay, and then here M2. Here M2 is the G0 type. Okay, so M2 and M4 are the Z0 or ZI type. Z0 ZI means inhibitory type. So in all such cases, in intracellular signaling pathways, decreased cyclic AMP. Okay, if it is GS, increased cyclic AMP. Okay, so these are common. If wherever GQ and GS comes, so these are the second messengers released. Okay, and then it's a universal truth. Then here there are 5 types of muscarinic receptors: M1, M2, M3, M4 and M5. So M1, M3 and M5 comes under GQ subtype, and M2 and M4 comes under the GIS Z0 subtype. And here in the M1, M3 and M5, IP3 and DAG and opening of calcium channels is the transducer mechanism. In case of M2 and M5, M2 and M4, decreased cyclic AMP and potassium channel opening, inhibitory effect. If potassium channels opens, what happen? Hyperpolarization, repolarization, relaxation of the cell will take in place. Okay, so inhibitory effects will take in place. Okay, here so this is regarding the transducer mechanisms. Coming to the location, here M1 are present on the these are considered as neuronal, so these are considered as cardiac, and these are considered as the skeletal muscular glands. Okay, so here in this M1 neuronal means these are present on the CNS and also present on the autonomic ganglia. Okay, here, so these are present on the autonomic ganglia, CNS. In the CNS especially it is present on cortex and hippocampus and striatum. Okay, and along with that it is also present on the gastric glands. Okay, and lower esophageal sphincter. Okay, so this is esophagus. Here one sphincter is there and here one sphincter is there. Okay, so here this lower esophageal sphincter also, these M1 receptors are present on stomach, gastric glands, parietal cells. Okay, and also on the autonomic ganglia and also on CNS. Okay, so coming to the M2 is especially cardiac, means present on the heart. Okay, it is present on the SC node of the heart, AV node of the heart, bundles of His of the heart and ventricles, etc. Okay, ventricular cells and everything. Okay, and they also present on the autoreceptors of cholinergic nerve endings. For example, what are autoreceptors? So for example, if acetylcholine is released from these nerve endings, here only the receptors are present. Okay, so some of the M2 receptors are also the autoreceptors, and then some of the muscles also contains the M2 receptors. Okay, along with that, here coming to the M3, so M3 is mostly present on various effector organs. Okay, so various visceral organs, like which is present on the bronchial smooth muscle, and which is present on the bladder, and which is present on the GIT. Okay, and which is present on the ureter. okay, and which is present on the various glands like salivary glands, lacrimal glands, sweat glands, etc. Okay, and which is also present on the smooth muscles of eye. Okay, so these are the location of various muscarinic receptors. Okay, so when these receptors are stimulated, what happened? So by through the stimulation of M1 receptors, which causes the here CNS, which is responsible for memory and cognition. So that's why these are useful in Alzheimer's disease. Okay, and here M1 receptors also associated with also present on gastric glands, so that's why they are responsible for acid secretion, and they cause the relaxation of the lower esophageal sphincter. Okay, and then here on heart, they are present on SA node, which causes the opening of potassium channels on the SA node and causes hyperpolarization. Okay, so that's why decreases the SA nodal activity. If SA node depolarization is decreased, means rate of depolarization is decreased, means heart rate will also decrease, because heart rate is depends upon the number of depolarizations by the SA node. Okay, and which decreases the heart rate, and which decreases the which also increases the effective refractory period of the AV node. So that's why, which slows the AV conduction and which decreases the force of contraction as well. Okay, force of contraction of the ventricles. Okay, which decreases both heart rate, AV conduction, and force of contraction. So this force of contraction we called as inotropy. Okay, means which has all the negative effects. Negative inotropic effect. Heart rate we considered as chronotropy, negative chronotropic effect, and AV conduction velocity we considered as dromotropic effect. Okay, negative dromotropic effect. All the effects on heart is negative effects. So most of the cases autoreceptors are associated with the negative functions. So what happened when these receptors are stimulated? So which decreases the release of neurotransmitters from the nerve endings. Okay, and then here coming to the third one, so here which causes all the smooth muscle contractions, which increases the bronchoconstriction, which causes the contraction of the detrusor muscle. For example, here coming to here, so here the muscles, detrusor muscle contraction, here the detrusor muscles are present, so these muscles are considered as the sphincter muscles. Okay, so for urination to takes place, for the micturition, so these muscles has to be contract, and these muscles has to be relaxed, voiding should be taken place for the urination. Okay, here this is done by the parasympathetic nervous system, so that's why which is responsible for micturition. And here, so entire GI tract muscles are contracted, and sphincter muscle is relaxed. Okay, so contraction pushes the food into the lower part. Okay, so that's why which causes the defecation. Okay, and which is responsible for urination, and which is responsible for defecation, and which causes the bronchoconstriction, and which causes the which increases the tone of uterus. And then and also which increases various glandular secretions, like, so which increases the salivation, which increases the pharyngeal secretions, which increase the tracheal secretions, and which increases the pancreatic secretions, which increases the intestinal secretions, and everything will be increased by the M3 receptors. Okay, so stimulation of if when acetylcholine binds to the M3 receptors and all these organs, so will produce all these effects. Okay, and that's why it is involved in the digestion. And then here selective agonist. What do you mean by selective agonist? Here, if acetylcholine will act on all these receptors, both muscarinic receptors and nicotinic receptor. But coming to the selective, means selective, if we want this effect only, we want to increase the gastric secretion, acid production. Okay, so we have to stimulate these receptors only. Okay, so if we want to dilate the bronchioles, okay, so for this we have to block these receptors only, no need of all these actions, right? So that's why either we give selective agonist or selective antagonist, depends upon the action we need. Okay, so the selective agonist for the M1 receptors are the MCN343A or oxytrimorine. Okay, and then for M2 methacholine and for M3 bithanicol. Okay, so and then for the M1 selective antagonist is pyrazapine. Okay, and then oxytromirin, sorry, metoctramine for M2 and darifenacin and sulfenacin for M3. Okay, so this is regarding the muscarinic receptors. So coming to the nicotinic receptors are also classified into two types. Nicotinic receptors are also of two types. Okay, so all these are what the receptors in the parasympathetic nervous system are receptors for the acetylcholine. Okay, so these are of two types, right? So here NM is present on the ganglia, autonomic, neuromuscular junction. Okay, junction between the muscle and the neuron. Okay, skeletal muscle and neuron. So responsible for muscular movements, muscular contractions. Okay, and here NN is present on the autonomic ganglia. Okay, so here connection of these two neurons, pre and post ganglionic neurons. Okay, here these receptors are present, and NN receptors are also present on the adrenal medulla. Okay, and here we already discussed. So these nicotinic receptors are the inotropic receptors, right? So they have pentameric structure like this rosette like structure. Okay, which have 4 transmembrane helices. Okay, and internally one pore is there. Okay, so through that ions will enter. Stimulation of these receptors causes the uh, entry of ions into the cell and stimulation of the cell. Okay, and then so they act through opening of the sodium and potassium and calcium channels. So coming to the selective agonist here, trimethyl ammonium here and nicotine. In case of phenone, nicotine and dimethyl pyrronium. Okay, so in case of antagonist here tuberculorin and bungarotoxin, and here hexamethonium and trimethoprim. Okay, so these are regarding the receptors and neurotransmitter. Okay, so now we know all the functions of parasympathetic nervous system, right? So which is responsible for glandular secretions, and which is responsible for pupil constriction, which is responsible for pupil ciliary muscle contraction, which is responsible for the gastric secretions, and which acid secretion, and which is responsible for memory and learning, motor functions, and which is responsible for all these are how all these effects are produced through the stimulation of these receptors only. Okay, then here we'll talk about the parasympathomimetics. Okay, so here coming to the parasympathomimetics, what do you mean by parasympathomimetics? What is the other name? So we also consider them as cholinergic agonist, and we also consider them as muscarinic agonist because they stimulate the muscarinic receptors. Okay, and they also considered as the cholinomimetics because they mimic the effect of acetylcholine. Okay, and then so these parasympathomimetics, so whatever the parasympathomimetics, so these are of two types. Okay, so these parasympathomimetics are of two types. So one is direct acting one, and another one is the indirect acting one. Okay, so here direct acting means what? So they directly acting on the muscarinic and nicotinic receptors. They have structural similarity with acetylcholine, so that's why instead of acetylcholine they bind, and they have more affinity for these receptors. That's why they can bind and they stimulate the all the effects. Okay, parasympathetic effects. And what are indirect one? Here indirect one does not have any structural similarity with acetylcholine, so they do not stimulate these receptors, but they increase the availability of acetylcholine in the synaptic cleft. Okay, if more acetylcholine available, more will be the stimulation of these receptor. Indirectly, by increasing the availability of acetylcholine, these effects are increased. Parasympathetic effects we are increasing, so that's why, so they are also considered as the parasympathomimetics. How we can increase the acetylcholine? By inhibiting the enzyme, by inhibiting its degradation. How it is degraded? By the enzyme acetylcholinesterase. Okay, so by inhibiting acetylcholinesterase we are inhibiting the acetylcholine degradation and stimulate the muscarinic and nicotinic receptors. Okay, so this is regarding the parasympathomimetics. Okay, so then we'll go for uh, classification. Okay, so this is the classification. So among direct acting one cholinergic agonist, we have cholinester's and alkalides. Okay, so examples are acetylcholine, methacholine, carbachol, betanicol, and alkalides are muscarine, pilocarpine, and aricoline. Okay, among anticholinesterases we have reversible and irreversible. Reversible means, so they acts by binding to the acetylcholinesterase enzyme. Okay, so means upon certain time they released from this enzyme. Okay, so those that's why the effect will be reversed after certain time. Okay, so that's why they are considered as reversible. So this irreversible means what? So they bind covalently with this enzyme. So that's why after lots of time also this drug won't be released from this enzyme. So that's why they consistently uh, acetylcholine degradation is consistently inhibited. So that's why more consistently the parasympathetic effects are produced. Okay, so that's why these are considered as irreversible. Okay, so irreversible we cannot use, so these are used as insecticides especially. So only the reversible one we can use for the various therapeutic functions. Okay, so among that we have carbamates and acridine. Acridine is tacrin. So carbamates are physostigmine, pyridostigmine, rivastigmine, edrophonium, donepezil, galantamine, and everything. Okay, so then ecothiopate, malathion, diazonin, and various nerve gases, tabun, sarin, soman, carbaryl, and propoxyl. So all these are irreversible organophosphates. Then this is the basic classification. Okay, so first we will start with the direct acting cholinergic drugs or cholinergic agonist. Okay, so how they act? They act directly by stimulating the receptors, muscarinic and nicotinic receptors. Okay, so depends upon their selectivity, they have different functions. Okay, so among all the direct acting cholinomimetics, so we have carbachol, betanicol, acetylcholine, methacholine, and alkalides, pilocarpine, muscarine, and aricoline, right? So among these, here only the acetylcholine. Acetylcholine clinically we cannot use this because which can uh, it is rapidly degraded in the plasma by butyrylcholinesterase, but if it is present, it can stimulate both muscarinic and nicotinic receptors. Okay, it is a non-selective, so which looks similar to acetylcholine. That's why it can able to stimulate all the receptors in the body like acetylcholine. Okay, so then methacholine, which only stimulates the M2 receptors, carbachol, which only stimulates the M3 receptors, betanicol, which also only stimulates the M3 receptors, not other nicotinic and muscarinic receptors. Okay, and here coming to the pilocarpine, so it stimulates both the muscarinic receptors and nicotinic receptors and autonomic ganglia. Coming to the muscarine, we already discussed, which only stimulates the muscarinic receptors, but non-selective. It stimulates M1, M2, M3, M4, and M5, but no nicotinic effects. So coming to the aricoline, this stimulates both muscarinic and nicotinic effects. But here we cannot use this muscarine and aricoline for the therapeutic purpose because these are the poisons. Okay, so here only the pilocarpine we can use, betanicol and methacholine we can use for the therapeutic purposes. Okay, so this is for paroxysmal supraventricular tachycardia initially. Now it is not using. So in this betanicol, which especially acts on the bladder and GIT, so that's why which is useful for here, which is responsible for urination, right? So that's why post-operative urinary retention purpose, or else neurogenic urinary retention. In this condition we go for this betanicol. Okay, and then for congenital megacolon also we can use. Congenital megacolon means enlargement of the colon due to chronic ulcerative colitis. Okay, so due to all these conditions, here in that this colon lost its tone, unable to contract, dilated. Okay, so in that cases, in order to increase its contractions, we can use beta nicol. Okay, so then pilocarpine, which has some adverse effects as well, but we can use it for Okay, here among all these, we can use carbachol, we can use methacholine, and we can use pilocarpine, and we can use betanicol. So these three we can use clinically. So remaining these alkaloids, muscarine and arecolin, these two are poisons. We cannot use clinically. And then here acetylcholine, it won't work because it is rapidly degraded by the enzyme. Okay. So here methacholine, which only selectively acts on M2 receptors, where the M2 receptors are present on heart. So that's why. So which decreases the heart rate and force of contraction. That's why which is useful in paroxysmal supraventricular tachycardia. Okay. So here beta nicole, which is selectively acts on the bladder and GAT. So that's why which increases the contractions of all this, which is responsible for urination, right? So that's why which is useful in the urinary retention cases, difficult in urination situations, we can go for beta nicole. Okay. And in case of decreased muscle tone, muscle GAT contractions, in that conditions, congenital megacolon, we can go for this beta nicole. Okay. So this pilocarpine, here coming to the pilocarpine, so pilocarpine will act on the eye basically, so which diffuses into the cornea, and which acts on the eye. So what are the effects of what are the parasympathetic effects on eye? So which causes the contraction of pupil, which causes the meiosis, and which also causes the contraction of the ciliary muscles. What ciliary muscles are responsible for? Ciliary muscles are responsible for the adjustment of lens for the near and far vision. Okay. So during near vision it will be curved more, during far vision it will be flat more. Okay. So in for this it is helpful. Okay. So this contraction of the ciliary muscles for a longer time causes the opening of this trabecular meshwork. Okay. So here causes the removal of the fluid from this anterior chamber into the Schliemann canal. Okay. So the, which is also responsible for reduction of intraocular pressure. So that's why, so this pilocarpine we can also use for glaucoma, but now the pilocarpine, these parasympathomimetics, we can use for used as a third line drugs. All the miotics and all these drugs we can used as a third line drugs. Okay. So then among, we all discussed about all these drugs. Okay. Except pilocarpine is natural source, which is obtained from Pilocarpus microphyllus. So muscarine, which is obtained from 3 different plants. Okay. Arecolin is obtained from Areca catechu, so which stimulates muscarinic and nicotinic receptors and CNS, but which penetrates the CNS more. Okay. So that it stimulates here it stimulates both the nicotinic and muscarinic receptors, and which penetrates the CNS more. Okay. So that's why which is in CNS, so this cholinergic transmission is responsible for memory. Okay. So that's why it is useful in the dementia before, it is tried for dementia before. Okay. But here, so these are the uses and pharmacological effects of various cholinomimetics, direct acting cholinergic drugs. But here the acetylcholine, so which acts on, it is a non-selective, right? Okay. So it is non-selective means which acts on all the receptors. Okay. Which acts on both muscarinic receptors and nicotinic receptors, and it able to cross the CNS when it is injected into the brain, which also acts on the CNS. Okay. So that's why it has all the effects of parasympathetic nervous system. Okay. So that's why we'll discuss the pharmacological effects of acetylcholine as a prototype drug. Okay, first drug here. So coming to the pharmacological actions of acetylcholine, exogenously given acetylcholine drug. Okay. So which has all these effects. Okay. So which has muscarinic effects and nicotinic effects, and it also have the effects on CNS. So first coming to the muscarinic effects, which has effects on, first on heart. Okay. On heart, what are the muscarinic effects? So by stimulating M2 receptors, this acetylcholine will stimulate the M2 receptor and decreases the heart rate, decreases the AV conduction, decreases the force of contraction. Okay. So these are the effects of acetylcholine on heart. Okay, so then on blood vessels. Okay, so generally smooth muscle contraction and relaxation will take in place because of the smooth muscle, vascular smooth muscles, middle layer of the blood vessels. But here these muscarinic receptors, especially M3, smooth muscles are associated with, on smooth muscles M3 receptors are present, right? So these M3 receptors are present on the endothelial cells of the endothelial inner cells of the smooth blood vessels. Okay, so that's why this stimulation, instead of causing smooth muscle relaxation, so they cause to smooth muscle relaxation not through the relaxation of smooth muscles, so through the release of indirectly through the release of EDRF, nitrous oxide, endothelial releasing factor, that is nitrous oxide. Okay, so this will indirectly causes the relaxation of the smooth muscle. Okay, here they do not directly relax the smooth muscle, so they relaxes the smooth muscle through the release of nitrous oxide. Okay, so the apart from that, here through through M3 receptors, which causes the dilation of the smooth muscles in the penis. Okay, so that's why which is responsible for erection as well. Okay, and then here on bladder, on various smooth muscles, first we'll start with the bladder. Okay, here which contracts the detrusor muscle and relaxes the sphincter muscles, so thereby it causes the urination. Okay, so on GAT, which contract entire GAT and relaxes the sphincter, causes the defecation and causes abdominal pain, colic, etc., because of increased contractions. Okay, and then which causes the bronchoconstriction. Okay, and then which causes the uh, contractions of ureter. But here this exogenously taken drug have effects on all these things. Okay, these three muscles especially. Okay, so then coming to the other effects here, which also has the effects on the iris muscles, and then which also have the effects on the ciliary muscles. Okay, here especially on the iris muscles, we have two types of muscles, iris muscles. Okay, so one are circular muscles, so this one internal one, so and another one are the radial muscles. Okay, so here in parasympathetic nervous system, this acetylcholine, so through the stimulation of M3 receptors on eye, so which causes the contraction of these circular muscles. Okay, so contraction of these circular muscles causes the pupil constriction, so contraction of these radial muscles causes the pupil dilation. But here contraction of the circular muscles of the eye, this acetylcholine causes contraction of the circular muscles, that's why which causes the pupil constriction, nothing but miosis. Okay, and which also causes the contraction of this ciliary muscles as well. Okay, increases the uh, curve of this lens. Okay, and also causes the opening of trabecular meshwork and removal of the aqueous fluid from the anterior chamber. Okay, so that's why they relieve the glaucoma as well. Okay, so these are the effects on eye. Then they also have effects on various glands, so they increases the sweating, salivation, lacrimation, and they increase the respiratory secretions, gastric secretions, but they have less effect on the pancreatic and intestinal secretions. Okay, so all the above one are the muscarinic effects, so these are it can also act on the nicotinic receptors, so which acts both on the NM receptors and NN receptors, means by acting on NM receptors, which increases the skeletal muscle contractions, and by acting on NN receptors, which is the release of NN receptors, where it is present on adrenal medulla, so that's why it increases the catecholamines release, and which increases the which can stimulates the autonomic ganglia, both parasympathetic and sympathetic ganglia. Okay, so then here which can also when it is injected into the brain, so in the CNS, which causes the memory and which is responsible for memory and learning, so that's why which initially produce the arousal effects, then followed by the depressive effects. Okay, so this is regarding the direct acting cholinergics. Okay, among all those, so we can only use bethanicol and pilocarpine clinically, so remaining all not used clinically. Okay, so coming to here, so these are the anticholinesterases, right? So among anticholinesterases, how they act? So they act by binding to the cholinesterase enzyme. Okay, so and then thereby they prevents the binding of acetylcholine with this cholinesterase. So when the acetylcholine bind to this receptor only, it will be broken down into choline and acetate. Okay, so here there is no space for the acetylcholine to bind with this enzyme, because this enzyme is blocked by the drug. Okay, so here depends upon the intensity of the action. Some will permanently block this enzyme, some will temporarily block this enzyme, so depends upon that. So these are again classified into two types. Okay, so how many types? Those are reversible and irreversible. In reversible, they temporarily block the enzyme. Okay, and then in irreversible, they permanently block the enzyme. So that's why there is no degradation of acetylcholine. Acetylcholine is consistently producing, and consistently the muscarinic and nicotinic effects are produced. So that's why it will lead to toxicity. Okay, so that's why we cannot use these irreversible one. Okay, we can use these as a insecticides, as a pesticides. Okay, here in the reversible we have carbamides and acridins. Okay, examples are physostigmine, neostigmine, pyridostigmine, rivastigmine, edroponium, donepezil and galantamine. Acridin is tacrin. Okay, so here again among these, some are tertiary amines and some are the quaternary amines. So quaternary ammoniums are water soluble. Okay, and the tertiary amines are lipid soluble. Okay, so depends upon that, they are again classified into, depends upon the solubility, they are again in reversible one are again classified into lipid soluble and water soluble. Okay, so lipid soluble have physostigmine, tacrin, donepezil, rivastigmine and galantamine. So here water soluble are neostigmine, pyridostigmine and edrophonium. Okay, here so depends upon their solubility. Okay, some they also differ in the pharmacological effects. All what effects they produce? So they produce the parasympathetic effects. Okay, so depends upon here lipid soluble, so that's why they diffuses even to the blood brain barrier, into they even enter the CNS, so that's why they produce CNS effects more. So they cross the cornea, so that's why they produce the effects on eye more. Okay, so they produce muscarinic and CNS effects more. Here water soluble, because of water solubility they won't cross the blood brain barrier, that's why they do not produce CNS effects and they do not produce muscarinic effects. Okay, so they produce the effects more on skeletal muscle, NM, than all these things. Okay, so because of that they also differ in the pharmacological actions. Okay, so all these drugs, they produce similar effects as that of acetylcholine, as that of direct acting parasympathomimetics, but depends upon the properties, depends upon individual properties, they possess individual pharmacological actions. Okay, here coming to the mechanism of action, so depends upon, here we have different categories of drugs, right? So one here acetylcholine, so this is generally acetylcholine when bind, here this enzyme has two binding sites. One is serine binding site, that is called a stereotic binding site, another site is called as the cationic binding site, or else they have COO plus COO minus, so that's for anionic site, stereotic site and anionic site. So here acetylcholine can bind to, generally in normal physiology acetylcholine can bind to these two sites, so whereas hydroponium only binds to the anionic site. So whereas carbamides, they bind to both anionic site and cationic site, whereas organophosphate, they only bind to the stereotic site. So depends upon that the reversibility of the enzyme will be present. The duration of the binding to that enzyme is differ. Okay, so that we'll discuss here. So this is generally acetylcholine here. So this quaternary ammonium site will bind to the anionic site, and this ester side will bind to the acetate side, will bind to this serine residue. Okay, so then upon this when it binds to this serine residue, okay, upon binding an anionic site. So when it binds to the serine residue, so this choline will be broken down, okay. So then acetate will still bind, which causes the acetylation of the enzyme. So this acetylated enzyme rapidly undergo extremely undergo hydrolysis. So that's why here rapidly this acetic acid is removed. Upon this will take hydroxyl group and serine again will take hydrogen group, and rapidly the enzyme is free from acetylcholine, okay. So then it is readily degrade another enzyme, okay. But in case of carboxylated drugs, here the carboxylated enzyme slowly undergo hydrolysis. So that's why here it will present on the enzyme site for about more than 30 minutes, okay. But after 30 minutes it will be removed from the drug, from the enzyme. So that's why enzyme is available for the acetylcholine after 30 minutes, okay. Until 30 minutes the acetylcholine degradation is inhibited, okay. So then in case of phosphorylated organophosphates, they remain bound to this esteratic site for a longer period, okay. So this binding of phosphate group to this esteratic site form a covalent bond. So this bond won't be it won't be reacts with water simply, it won't undergo hydrolysis with water. So that's why it won't be taken up from this place, okay. That's why acetylcholine won't be degraded, because there is no space for acetylcholine, it was occupied by the organophosphates. So that's why acetylcholine will be consistently produced at that area, okay. So upon if it is initially, if the after organophosphate pesticides poisoning, so if initially we can identify if it is organophosphate poisoning, so we can easily treat with pralidoxin, because so these pralidoxin groups will donate the highly reactive groups, okay. So that's why which causes the removal of this drug from the binding site. This pralidoxim acts by removing this drug from the enzyme site, okay. But upon aging, here one alkyl group is there, that alkyl groups are there, okay. So here all these alkyl groups, dealkylation will takes place, and this bond becomes more strong, okay. It won't be reversed by the pralidoxim. So that's why, so pralidoxim will works initially after the poisoning, okay. So after long time we'll go for the anticholinergics, okay. How the anticholinergic works? By blocking the effects of acetylcholine, by blocking the receptors, okay. So for the anticholinesterase poisoning, organophosphate poisoning, initial days initial hours we'll go for pralidoxim, for later hours we'll go for the anticholinergics, okay. So then again they are lipid soluble and water soluble, because some have quaternary ammonium derivative and some have tertiary ammonium derivatives, and then those are lipid soluble that crosses the CNS, and they cross the eye. So that's why they have effects on eye. Muscarinic and CNS effects are more prominent. So here in case of water soluble, skeletal muscle effects are more prominent rather than muscarinic effects. So that's why the uses for these also different, okay. So they produce all the effects, like they increases the secretions, they increases the contractions, and they increases the skeletal muscle contraction, they stimulate the autonomic ganglia, they have CNS effects and everything, but depends upon the drug, effects will be differ, okay. So let's see the uses of these anticholinesterases here. So first use is myasthenia gravis. So what do you mean by myasthenia gravis? Weakness of muscle. How? So because so here we have NM receptors in the neuromuscular junction, right? So these NM receptors, for these NM receptors, auto antibodies are produced. Autoimmune disease it is, okay. Auto antibodies are produced by the body, okay. So that's why these auto antibodies occupies these receptors. So that's why, so less availability of the receptors here at the muscle, there is no availability of or less availability of the enzymes. That's why even acetylcholine released in sufficient amount, so there is no muscle contraction because of the decreased availability of the NM receptors. Okay, so how can we treat this condition? By giving the anticholinesterases. So how they works? They increase the availability of acetylcholine, so that's why they uh, stimulate the available NM receptors consistently. Okay, so here water soluble one, neostigmine and pyridostigmine, we can use for this myasthenia gravis because the skeletal muscle effects are more prominent for water soluble drugs, right? Okay, then here for glaucoma, lipid soluble one, especially the physiostigmine we can use for the we can use in eye conditions. Here they cause meiosis. Okay, they constrict the people by constricting the circular muscles of the iris, and they also constrict these ciliary muscles. Okay, so that's why they cause the opening of this trabecular meshwork. Okay, so trabecular meshwork, and causes the removal of the fluid from fluid into this Schliemann canal, and promotes its elimination. So that's why aqueous chamber pressure within the anterior chamber will be reduced, and then intraocular pressure within the anterior chamber is relieved, and then glaucoma is relieved. Okay, so that's why here lipid soluble one physiostigmine we can use for used as a miotic. For the Alzheimer's disease, here also lipid soluble one we can use, but not physiostigmine, galantamine, donepezil, tacrin, these we can used rivastigmine. So these we can used for the Alzheimer's disease because they can penetrate the CNS. They stimulates the cholinergic receptors. Okay, so here Alzheimer's disease, what it is due to the degeneration of cholinergic receptors in the CNS. Okay, so that's why here by giving anticholinesterases we increase the stimulation of these cholinergic receptors in the brain. Okay, especially the lipid soluble one we can use for the Alzheimer's disease. Hi, here and then we can also use these anticholinesterase for post-operative paralytic ileus. Okay, and then for urinary retention, here also we can use water soluble one, neostigmine we can use, and then for the Curer poisoning. Okay, here for the Curer poisoning also the skeletal NMJ neuromuscular junction is affected, so that's why here also we can go for neostigmine, and cobra bite, which is similar to that of Curer poisoning, so that's why in such cases also we can go for the neostigmine. So for the myasthenia gravis, for the cobra bite, for the paralytic ileus, and for the post-operative decurarization, Curer poisoning, for all these cases we go for neostigmine, and for the glaucoma as miotic, and we can go for the for all these we can go for neostigmine, for that we can go for physiostigmine. Okay, here and for the anticholinergics poisoning also we can go for physiostigmine. Okay, so physiostigmine is for glaucoma and belladonna poisoning, and neostigmine is for myasthenia gravis, cobra bite, and Curer poisoning, and galantamine donepezil, rivastigmine we can use for Alzheimer's disease. So this is all regarding the parasympathomimetics, classification, mechanism of action, uses, okay, and everything.